So, welcome to the Pharmacist Diaries podcast.
Thank you. Thank you. Yeah, when you messaged me on LinkedIn, I was like, wow, you picked me? Like, yeah, go for it.
No, I go onto LinkedIn and I actually look at people's profiles and I do scan where you've worked, like what experience you've had, and you've got, 8-9 years experience now and you've done loads so far. And I haven't had anyone with HIV specialty come onto the podcast yet. And plus I just saw that you were getting involved in the additional kind of community for HIV. So I thought this is a good opportunity to find out, what your passions are and why you're kind of going down that specialist route. And LinkedIn is quite good actually seeing people's pathways. You're quite a generalist and then you kind of find your way into the specialist area. And within that, you've had a couple of roles as well. So it's quite exciting.
Yeah.
I guess if you'd like to introduce yourself and just tell us a little bit more about you.
Yeah. My name's Stephanie Tyler. And I, became a pharmacist around 8-9 years ago. So nearly at that 10-year annual leave increment. Started off, I guess I'll talk about how I kind of got into pharmacy in the first place. I'd love to say that I had a kind of real passion for pharmacy at the beginning. I didn't. I just kind of stumbled across it. And I remember this kind of I've got a distinct kind of vivid image of me and my mum were sitting in our family home in the garden on our trampoline, which I kind of spent most of the time sunbathing on the trampoline rather than actual trampolining. But anyways, we were sitting there and she got out the orange Penguin career guide book.
Okay.
Which lists kind of all of the different careers you can think of, what it involves, what you have to do to get there. And all my family are accountants. So my mum, my dad, my brother's doing his accountancy exams, my uncles, granddad. So I had this very strong influence to go down financial route. But I was do I really want to count people's taxes each month? No. So I've kind of been not the black sheep of the family, but I haven't followed that kind of general route. And I thought, okay, sports and medicine, that's kind of my two passions I had at school. And we went through all the different careers. So there was nutritionist, sports science, personal training, forensic science, marine biology, all of that. And then pharmacy came up and I was studying drugs, that's quite cool. And I knew I wanted a degree which would actually get me a job at the end of it, had a distinct kind of career path. So I went for that and I got into University of Bath for pharmacy, which I didn't think I would get because my chemistry teacher, I don't know if they had it in for me, but they just wouldn't predict me the grades I wanted. But I was able to get the grades and Bath accepted me. And at the time I thought I would go into pharma and be one of the people that invent some cure or, some new drug. And then I started doing all the lab work at uni and I was oh, this is really not for me. And then I thought, I'll be, a high street chemist, community pharmacy. And at the time, I think, which is quite common, the general kind of public perception, that is what a pharmacist does. And I kind of thought the same. So I ended up doing 2 kind of very short community pharmacy placements. One was a summer student kind of placement at Boots, which was really target driven, very commercial. I didn't really like it at all. And then I did a hospital pre-reg with a 1-week stint in community pharmacy. It was a really sweet, independent pharmacy, lovely pharmacist. But when I was there was kind of no clinical aspect, which is what I was used to. So we were handing out antibiotics and no one was checking penicillin allergy, or no one was counselling on medication. And And then when I was dispensing, the labels would like print out all the interactions of the patient's like medication, what they've had before. So I was like printing them all out. And then the pharmacist was like, no, like we don't need to look at that. And it's going to use up all the ink on the label printer. So stop doing it. So I was like, oh, what are we actually doing here? And then I told the pharmacist that I'd finished my checking logs during pre-reg. So he got me like checking some of the medicines. And I was like, okay, this is cool, bit of responsibility. And I thought the pharmacist was like checking it after me. But what I then realised is it was just going out to the patients. So I was like, oh my God, like nothing's being checked by a pharmacist. So I had to turn around and be like, hey, you know, I'm just a pre-reg. I can't actually clinically screen and do the final sign off. So I remember going home having like nightmares of like, oh my God, what have I checked? I'm not ready for, you know, that thing. So yeah, community pharmacy was kind of out the window at that point. And then, I did a few placements in hospital, absolutely loved it. And ended up moving back home to Brighton and doing my pre-reg at Brighton Hospital, which is, you know, really large teaching hospital. And I was one of 7 pre-regs, I think, at the time. So it was like, you know, a really nice team of us. And I was quite lucky because I was based at the smaller hospital, which was called Princess Royal Hospital in Haywards Heath. So I kind of had like the best of both worlds in the pre-reg, because I was at kind of a smaller hospital with a small team, which I find amazing now, but we had time to like go for tea breaks at like 10:30 every day, have a little gossip. And but then I'd still be able to go to the main hospital, do all of like the specialities. So I'd do like renal, oncology, neurology. Every rotation I'd be like shadowing on the ward rounds. And then cardiology, I even got to see like open heart surgery, coronary artery bypass. So I was so lucky there. And then I kind of got quite anxious towards the end of the pre-reg that I wasn't going to be able to get a job. So I went for the first Band 6 job that came up on NHS Jobs, which was in Guildford, so the Royal Surrey County Hospital. And I got that. I kind of accepted it and moved there, no friends or family, and kind of, you know, missed out on all of the STEP programs. Brighton then offered like loads of Band 6 jobs. So moved there into a house share with 5 guys and me. And I remember when I looked round, the estate agent said there was going to be another girl. And then when I moved in, I don't know what happened, but anyway, yeah, there was me and 5 guys, but it was a 10-minute walk from the hospital. So, you know, location was great. And I mean, Guildford was an amazing place to learn. And I think it was quite good that was my first Band 6 job, because people didn't know me as a pre-reg, I guess. So they didn't have that kind of like already kind of thoughts. I did kind of all the general rotations of a Band 6, MI, aseptics, clinical. And I was quite lucky towards the end. I got to do one of their new rotations in like antimicrobials and med safety. So that was really cool. But what wasn't cool was the on-calls at Guildford. So like we know about like residency. You've done I've heard you've done residency before, GSTT residency, and like, you know, they are horrendous, the nights, the bleeps, but then at least I know at GSTT they get the day off the next day. So how it worked at Guildford was I would do the on-call every other Wednesday night, and then weekends, I can't remember how many, like maybe every month or 1 in 6. And so the Wednesday I would work the day, do the late shift, lock up, take the bleep home. But it was about I think a 600-bedded hospital, so it was quite big. And we'd get bleeps like all through the night. And there was no like emergency drug cupboard, so I'd have to come in the middle of the night. We were like the suppliers for like TPN, gangcyclovir for all the outside Surrey hospitals as well. So we'd have to kind of go in and do that. And then you'd come in on the Thursday, the next day, like nothing happened, and do your shift. And then on the weekends, we would again be the late night pharmacist on a Friday, lock up, take the bleep home, come in on the Saturday, do the Saturday shift, go home Saturday. And then on a Sunday, there was no Sunday service at all offered in the pharmacy. So you would get bleeped from the morning. You'd kind of like write down all of the bleeps that you'd get, come in at 12 o'clock, and you'd have to kind of beg your friends, another pharmacist and a technician to come in at 12. You'd open the hatch and there'd be like a line of nurses and drug charts waiting for you, and you just accept them. And then you'd work there for like 4 or 5 hours, just churning out all the work. And then, yeah, go home, come back Monday morning like nothing had happened. So I'd do like a 70-hour week or 80 hours. And I used to get like PTSD from the bleep. I could hear the bleep just going all the time. I can still hear like that switchboard noise when you go through and then, you know, dial the extension number and stuff. It
is completely exhausting.
Yeah.
Physically, mentally, emotionally, knowing you're on call in that way. I feel the same way about parenting, because you're on call 24/7 and that baby, yeah, there's no break. The baby's going to cry at any moment. And even when you put the baby down, you're still, you're on call. You know, she could wake up at any time.
Yeah.
And now we got 2 kids, so anything can happen. And it is that same feeling. Because all you want to do is rest or just get a bit of sleep. And you know that it's hard to then fall asleep because you're anxious that the bleep's going to go off or a baby's going to cry. And each hospital is obviously really different. And I think in some respects that experience is a lot worse than being a resi. Similar to GSTT, and what I dealt with in Oxford was that you would, your night shift was your night shift. And I think GSTT, that there are shifts that are those long days and you do nights, and it can be really exhausting. And, but we used to come in at sort of 4 o'clock in the evening, and we would go straight to the dispensary. And with a 1,200 to 1,400 bed kind of hospital, there is a lot of work to process at that time of day. But at 4 o'clock there would be minimum 10 to 15 people working in that dispensary at that time. People would be on late shifts and allocated to late shifts. You would have another resi with you until sort of 8, as well as lots of techs to support you, and other pharmacists who are going to help you to kind of like lock up effectively. And then from 8 o'clock, you're kind of on your own. But being in the hospital gives you less anxiety to start with, because you're in your comfort zone of, I've got all my resources with me. I can label, I can dispense, I can run up to a ward to look at a drug chart if I really wanted to. Because if there was a patient that came in that you felt blind talking to a doctor on the phone, you could get them to pod it to you, because we had the shoot system, or you could get them to bring it down to the pharmacy, or you could run up to the ward if you really wanted. So you could visualize. But when you're at home, obviously the difference between answering a phone call in that environment can be quite daunting. And also there's a lack of support. Like, we would have quite a few pharmacists who used to enjoy working late, or they would be in the offices in the back just getting on with bits and bobs till quite late at night on a regular basis. We had one peds pharmacist who would literally be there till 2-3 in the morning most nights of the week. His name was Paul. So we had support. Like, he would leave us chocolate bars on our desks at times just to keep us going.
But that all means so much. Yeah, chocolate bar.
Absolutely. It was usually like the giant Twix is what he used to buy us.
Amazing.
So from that perspective, you feel more comfort, even though it is extremely busy. And you obviously have a backup person that you can call who would support you. And I'm sure that
want to call them.
Yeah, you never want to call them. Yeah, sometimes our backups wouldn't answer, which was also dread when that happens. When you're really stuck and you need that support. But it can be a very challenging experience when you've first qualified and suddenly you're like dropped in it. But at the same time, you know, we talked about this in the car, that going out your comfort zone is really valuable in terms of your learning experience and becoming the person you are today. And sometimes having that responsibility is really useful in terms of decision making and being able to say, well, actually, this is safe, this is not. You know, I can give this answer with confidence and feel like I've done my best for the patient at the end of the day. So you do gain a lot of life skill, in fact, from those experiences. But the fatigue
is real.
is real. And it can be really, really hard. I wanted to kind of go back and ask you a little bit about the anxiety you felt from being a pre-reg and potentially not getting a job. What were your thought processes with regards to that?
Yeah, I guess I'm a planner, and
Okay.
I like to have everything kind of set out in stone. And yeah, it's all, I guess you never know what jobs are going to come up and when and if you're going to get them, particularly between pre-reg and band 6. It's not like you finish your pre-reg and there'll be enough band 6 jobs available at that time for you to carry on and get them. So yeah, I was very panicked, and I just thought, I'll just go for it. I'll just go for the first one that came up. And like, I did some research about the hospital, and you know, it seemed like really interesting. They had an oncology unit, big aseptics unit. And it wasn't too far from Brighton, my hometown. So I thought, you know, I can kind of travel back and forth. Yeah. But
it can be quite hard because you're right, jobs come out at different times and you can't, you're at a point where you're like, okay, well, I can make that application. I can accept the job. And quite a few trainee pharmacists do reach out to me and say, well, actually, I've been accepted here, but this job has now come up. And I feel, is it unprofessional for me to say yes to this organization? And then in the meantime, I'm interviewing elsewhere because that job looks really good. And it's actually what I really wanted, but it's challenging with the time. And because you don't know when the hospitals are generally going to put those adverts out, you kind of want to secure a place. Who doesn't want to secure a job at the end of the day? And people know there is competition, because if you wait too long, you then get put into a position where you kind of do need to take whatever job then comes up because all the places have been taken. Exactly. And financially, I think each year, each hospital does struggle in terms of how many band 6s they can recruit. At the same time, I think recently there have been more jobs than less because they've been upgrading band 6s to band 7 roles, because band 7s have left hospital and kind of gone out to the world of GP land or to kind of, you know, primary care in whatever form. And that way band 6s have been promoted into band 7 jobs, which have then released a lot more band 6 positions. So the junior pharmacists are quite fortunate from that perspective. My opinion on that is different because I just feel like sometimes we promote people a little bit too early. But again, I'm a little bit, I mean, I've only got 11 years experience, but back when I was training, there was no way that that would happen. And things are starting to evolve where you're having to put people into positions where they might not be quite ready, but you expect them to up their game and get themselves mentally prepared and ready for more responsibility and more opportunity. And it's good. Like, in some ways, if you've got a pharmacist who's self-sufficient and independent and takes responsibility and they're accountable, they'll do what they need to in order to get into that position. But if someone's not quite ready and you don't have the resource to train, then you put your team into a position where you've got someone who might struggle a little bit in that role. So I guess when you were doing your pre-reg and kind of rotating through all the different areas, and when you got your band 6, what were you thinking in terms of your career and what specialty areas that you enjoyed during that time?
I mean, I kind of enjoyed everything clinical, let's say. So yeah, I enjoyed, cardiology, renal, oncology. I wasn't set in stone with HIV at that point. I was lucky to do a couple of weeks in HIV at Brighton, which I thoroughly enjoyed, but it didn't, I wasn't kind of set. And I wanted to make sure I'd kind of, grounded my knowledge and I've got all the general basics covered. I didn't want to specialise too soon. So that's why, yeah, Guildford was good in that it was a rotational band 6. So yeah, I got to cover all the kind of general rotations, and the clinical rotations were really good because you got to actually be on the ward all day. You'd be like you and a technician, which I just loved that. And then started the diploma at the same time as well. But I'd been through all the rotations twice, and I kind of what I found, like, in my career thus far, I kind of have this like 18-month ick with jobs, and I get to that point and I'm like, right, I know how to do this, I need to move on, I need the next challenge, I need to step up. And in Guildford they weren't promoting anyone to band 7 unless you'd finished the diploma. And the one I was doing at the time was like 3 years long. And all my friends at the time were moving to London. And so I was kind of, potentially going to be left behind. And I never wanted to move to London. I was like, why would you want to go there? Why would you want to cram yourself into the tube every day or pay like extortionate rental prices, living costs, all of that? But a job came up at Ealing Hospital, and one of my friends got a job at Ealing, the other one got a job at Northwick Park Hospital, so like northwest London. And I got the job at Ealing, moved in with my friend. We lived in Harrow, which was amazing. We had this like huge 2-bed flat with like tennis courts in the middle of the complex. It was incredible. And I commuted from Harrow to Ealing each day for work, driving, which, for those of you who live in that area, know the Greenford Road, and the traffic is insane. And it's about a 4-mile journey, but takes 45 minutes to an hour. And I remember thinking when I was driving, I was like, why does everyone why are these drivers so aggressive and so angry? And I was getting tooted all the time. I was getting cut up. And it was very different to like Brighton, it's like Green Party, 20 miles per hour, max speed limits. Everyone's very liberal, easygoing. And I was like, oh my God, like people are just so angry in London. Yeah. And I got like 3 bus tickets in like my first month.
Oh no.
Bus lane tickets. Yeah.
I know what it's like because I was born in Sudbury. So
okay,
literally at the bottom of Harrow on the Hill where I was born and raised. So I'm totally aware. And every time I go there, because I've still got family there, and my husband's parents also live in that area. So whenever we go there, we're always getting anxiety because it's a completely different way of life to living in the countryside and driving. And people are so kind with driving here.
Yeah.
And as soon as you enter that area, it's, your radar for driving just goes on, and you start getting anxiety simply because people are just driving like lunatics.
Yeah.
It's quite stressful.
It really,
not what you needed on a daily commute.
No, not newly qualified as well. But yeah, once I got to Ealing Hospital, it was lovely, and the people were so kind, so lovely, and there was a big kind of social vibe. We'd go for like lunch every Friday at like the local Thai restaurant, and then every leaving due we'd go to the local pub called Viaduct, and it was so nice. I'd meet up with all the band 6s for lunch every day in the Costa Coffee, and yeah, I loved it there. but I got that like 18-month ick again.
There's nothing wrong with that though, is there? Do you feel like it's a good thing, a bad thing, or?
Yeah, I think it's a good thing, because when I get like complacent and comfortable in a job, I don't like it. So I complain when it's hard and challenging, but actually I hate it more if I know what I'm doing and I'm completely comfortable. So yeah, but Ealing was where I kind of found my passion for HIV. So I did my last rotation there was like antimicrobials, ID, HIV, so a bit split. And I fell in love with the speciality. It was such a pro-pharmacy MDT, and obviously I'm a little bit biased, but I do believe that like pharmacists have such a massive input in HIV, more than I think many other conditions. And that's purely because I think it's so complicated with all the resistance. There's so many drug-drug interactions, and adherence is so important with taking HIV medication. So, you know, the pharmacist's role for like counselling patients is incredibly important. Otherwise, you know, they may potentially deteriorate into AIDS-defining conditions or transmit the virus to someone else. So our role is so important. And, you know, it's one of the conditions which can only be treated with medication. You can't do surgical input. There's no physio. It is the medicines. And kind of looking after such a vulnerable, stigmatized cohort, and to be able to kind of make a difference was just so rewarding. And I kind of knew at that point, okay, this is for me. I'm gonna go for this. And a specialist band 7 HIV job came up at Chelsea and Westminster. And I mean, moving to London was quite a big deal in itself, but Ealing, you're kind of on the suburbs almost. You know, it's still quite green, but they're moving even more towards London. I was like, oh, what am I doing?
But you follow your passion.
Yeah.
You followed your love in pharmacy. Let me ask you one thing, because it'll be quite interesting to see, because you've had, you know, different jobs within the HIV specialty at different hospitals. So back then, when you first did that rotation, what was your day in the life like? What was your role like as a band 6?
So, I mean, in that rotation, I would cover, it would be split between, I'd be on the wards, which was right next to the HIV outpatient department. I just walk onto it, cover the wards in the morning, and that would be a mix of HIV patients, infectious diseases, TB, and I'd also do a bit of antimicrobial work as well. So I'd go on ward rounds, micro ward rounds, and review all of kind of the meropenem prescriptions, tazocin, that kind of thing. And then the HIV outpatient department was myself, the AA HIV pharmacist at the time, and a technician. And we would dispense all the medicines there. And it was sexual health and HIV, but it was a very small centre, but it meant, you know, you were working so closely with the consultants, with the practice nurses, and the patients. You just had such a rapport with them. They knew us. They knew. I mean, I was quite new, so they didn't know me, but they knew the pharmacist and the technician. And yeah, it was all confidential, because there was no other outpatients in that area. It was purely HIV. And I learned so much about counselling, you know, how to have kind of, I would say, like difficult conversations with patients, because you're counselling a patient at the same time that they've got a new diagnosis of HIV. So, you're balancing, okay, I know I need to give them all this information about the drugs, but actually like their mindset isn't going to be, they're not going to be in a place to absorb a lot of what you're saying. So you kind of have to think, okay, what is the main key points I need to get across here, and what do they need at this point? Because as you know, they ask the pharmacist questions they don't want to ask the doctor beforehand often. And one of the things I think helped me by quite a bit was Nina Barnett, one of the pharmacists, consultant pharmacists, gave like a 2-day course on health coaching techniques. And that really helped me because it kind of taught me, how do you communicate with patients and actually not solve, but kind of like, how do I say, how do you really find out what their needs are, rather than going through and just listing, okay, side effects, how to take it, food requirements, what are their needs? And also with the adherence side of things, it was like, okay, well, I can suggest to them to do a Dosset box. I can suggest to like do an app on their phone, which will help remind them. But actually, what is the patient what suits the patient? And flipping it and empowering the patient to think of like their own ideas for how to support themselves with adherence, and empowering them to like take control of their health, really.
Which is really challenging and something that we're not trained to do as pharmacists or pharmacy students. Because a lot of the time when we're studying undergraduate level and even postgrad level, we're taught to provide information and communicate fact. Of course, we learn how to build rapport, and we're told that that's really valuable. But the ins and outs of how to do that in quite a sensitive situation is really a skill. And health coaching is amazing because you're providing questions or identifying information from them, but they're the ones coming up with the ideas as to how they can implement and make their lives better and healthier, and how they can manage this condition long term. Because at the end of the day, they have to have that motivation and that self-motivation and drive to be a better version of themselves. So that's amazing. So do you know how it's Nina, did you say?
Yeah.
How she kind of got involved with that?
I don't know, to be honest. I know she's kind of quite well known for kind of going around and kind of teaching these techniques, because when I went to Chelsea, she was brought in again, which I thought, it was really valuable, because then, the next team was learning. But she might be quite a good one to get on.
Yeah, that's
on
a good
podcast.
idea, right?
Yeah.
No, but it's really interesting because it's a side of pharmacy that is, not known for all specialty areas. It's not that, you're empowering patients to that same respect in all specialties, nor do pharmacists have time in clinics to be, I guess, helping patients from that perspective. But a lot of what you said resonates with me well, because with palliative care, again, it's a very sensitive area in terms of information giving, and you've got a pediatric patient who's potentially just been born, and the parents identify that their child is not going to survive, and they didn't know. Some parents may know during the pregnancy that this is the case. Doesn't make it any easier. But if you're unaware that this is the situation you're going to be faced with, you've literally just given birth and you're going through your own emotions, your own physical changes, fatigue and all the rest of it. And then on top of that, you have to deal with the diagnosis, which is literally life-changing in the same respect as someone identifying they've got HIV.
Yeah.
And then you've got 25 drugs and 2 massive shopping bags of medications that they have to learn how to use. They have to learn how to administer to a baby. They have to know what the drugs are for, what the side effects are, like you said, and being able to do things from buccal administration, oral administration, subcut injections, identifying symptoms which relate to palliative care, whether it's shortness of breath or constipation, and a lot of the symptoms are similar to a newborn in general as well. So it's quite difficult to differentiate what's from what. It's interesting that you obviously have that similar experience with adults, and when we counsel patients on discharge, I usually put aside about 3 hours of time. I might be going on to the pediatric ICU. I ask both parents to join if both parents are available, and make the time to have 2 people listening to me, so more information is being taken in. And then I usually try and go back a second time, because I know that the amount of information that I've provided, maybe 10 to 15%, is probably absorbed.
Yeah.
We print out a Word document for the symptom management plan, and the consultants document what the symptoms look like for that child specifically. So it's very individualized. So everything is in writing. But when I started the job, and because palliative care for peds at Evelina is relatively new, we haven't had anyone in that role. So from my perspective, I felt this is overwhelming for a family to have a 10-page Word document. What can we do to improve the service? Because right now I feel like the amount of information I'm giving, what they're taking in is limited, and then the nurses and the consultants end up receiving lots of calls from an on-call perspective, which are all medication related. So how can we reduce that burden, but also empower the family at the same time and get them to feel more comfortable with the diagnosis as well as the symptoms that they potentially may see? So from my perspective, I started thinking about how can we change this symptom management plan, because it's literally 7 to 10 pages on Word of just pure words. Sometimes it's difficult to differentiate the drug information versus the paragraphs that describe that symptom. So when I started the job, I suggested that we split into 2 documents. So the drugs are all like in a table, similar to what you would give to a renal transplant patient, where everything's kind of drug names, the doses. For us in peds, we would put everything into mils, so they know, and the syringe size that they would use, the route of administration, how many times a day they can use it. If you're dealing with seizures, for example, and you're using midazolam, like how many minutes after the first dose can you give a second dose? We're providing that information, and then kind of any additional bits and bobs. And then in terms of the symptoms, we've split them into kind of leaflets, PDF leaflets. So that was just kind of the starting idea. And we actually, all the patients who are at home who are defined as palliative care patients, but potentially could be living, weeks to months to years in the community, but we still support them. Those parents have now got that version of the SMP, as we call it, and they're trialing it, and they had to fill in a survey to let us know which one they prefer. So though I'm on maternity leave, this is what's been happening in the background. But even that, I think, is a basic step in the right direction, however still not good enough. So I wanted to ask GSTT Charity for some funding to create some videos, because at the end of the day, if you're in a situation where your child is struggling to breathe but you're not really sure what that could be, you've got maybe a grandma at home or someone else with you, that someone could quickly open up that video and you're given a 1 to 2 minute video on how to administer the drug or what the symptoms going to be like, because reading a paragraph would be really stressful in that moment.
Yeah.
And you've been given this information during a counselling session, but hey, that could have been 2 weeks ago and the child has been stable but now deteriorating, so you've completely forgotten. So reading through that information can be quite challenging. So it's interesting to see how similar things are happening in other specialty areas. Do you have any good examples of stories of patients where you've made some like not interventions, but I guess using your health coaching skills and kind of empowering a patient to kind of make a decision on their own. Maybe you can think of one.
Putting me on the spot here.
Sorry.
No, it's good. Yeah, I mean, how many patients have I spoken to in the last 4 years? Let me think. I mean, it could be just like the simplest of things. So like with our HIV medicines, we can be quite strict in that we'll say, you need to take this tablet every day on the dot, no missed doses, otherwise you're going to get resistance, we're not going to be able to use the drugs, you're going to have to take multiple tablets multiple times a day, which scares patients a little bit. And so, putting the question back to them and say, talk to me, how do you take your medicines? How do you remember how to take them? Rather than telling them how they do it, just get them to speak it back to you. And the amount of times, the patient will say, yeah, I take it 9 a.m. every morning. I've only missed it. I've only delayed it by 20 minutes in I don't know, the last 2 years. And I'm like, you don't have to do that. We're not that strict. And just educating them and easing that anxiety. And then they're not worrying so much that they've missed it by 20 minutes, which that small bit of information, can change that person's the whole day, because they're, revolving, taking that tablet around a certain time in the day, or everything's fixated on taking that tablet on time, but actually you can fit that in with other stuff. And with breakfast or whatever, if breakfast is at 9, 10, 11, doesn't really matter, and that will mean that they're not kind of thinking so much about the medication, which is a reminder for a lot of people around the condition, which brings a lot of stigma as well. So to kind of, put it into their daily practice rather than putting so much pressure onto it, I think has made quite a big difference.
Yeah, I mean, I'm sure it can be, it's really daunting, and there's a lot of pressure around medications, because if you don't take them, the numbers show that you've not taken them.
Yeah.
The feedback is there.
Yeah.
And it must be horrible for them to come into clinic, have a blood test, and they get that feedback, and they probably feel guilty and disappointed with themselves. And then that guilt and disappointment can cycle into a depressive state even.
Yeah.
I'm not doing good enough and I'm not looking after myself. And, I guess you have to try and help them to become more positive about taking medications. And that whole counselling and that conversation that you have is extremely valuable to their care, which is why you probably feel so rewarded by seeing people really taking care of themselves in a different way. And I can imagine it's a really enjoyable job, though challenging.
Yeah.
The reward that you get and the feedback that you get from patients, and you really get to know them. This is the one thing I said in terms of, once I did all my rotations and what I was enjoying, like you, I loved everything and I just wanted to do everything, but that's not possible. And even as going into the band 7 route, I was like, I just don't know what to do. But I was quite fortunate that I met my husband and I moved to Dubai, so I didn't have to make those decisions. But I'm not sure what I would have done at that point, because I genuinely loved a lot. But what I do know about myself is that I love the educational side of pharmacy and counselling, and even now in peds. I love a parent, and it's because I am a parent. It makes it completely different in terms of building that rapport and truly understanding what they're going through, because you're now part of a family. You're part of a unit where you get their experience and what's challenging in terms of time and routine and getting kids to school and whatever else comes with parenting. But I knew that I wanted to be in an environment where it was a long-term condition, which you got to know the family or the patient themselves and you help them long-term, because at the end of the day, like, building that relationship for me is the be-all end-all for me. Like, I absolutely thrive in the environment where I get to know someone. And it's just part of my personality that I enjoy talking to people. I mean, I've set up a podcast and I'm enjoying conversation. We've never met before, and we're here.
Yeah.
So clearly, like, I know that's my passion, and finding that aspect in pharmacy has been really important to me. So palliative care is part of that. Like, you may be with a patient at end of life, and it happens in the hospital, but a lot of our patients stay alive for potentially years. So you're supporting that family through every aspect of their care from home, and it's really valuable. And that must be similar to what you go through on a day-to-day basis. You look forward to seeing some of your patients and seeing their progress, and what changes have you made, or how is your routine altered, where you're getting better at taking your medicines and your adherence has improved. The numbers show it, and it's really a positive experience for them to come into clinic and see, okay, yeah, this, I'm doing better and I can do this. So that kind of positivity is really valuable. So I guess in that role, you were going to clinics, you were covering ward rounds. What was it like as a band 6 working with consultants? Because when you have limited experience and you're kind of young and new to pharmacy, it can be quite daunting to work with a consultant and be quizzed by them on ward rounds, or what do you think about this, or how can pharmacy support? Sometimes that can be quite scary in the beginning, but it's enjoyable from the perspective that that your team is valued. So even if you don't know the answer then and there on the ward round, you can go back and find it. But what was your experience like from an MDT point of view back then?
I think I was quite lucky in that I'd just done a rotation in acute medicine, and one of the ID consultants was split acute medicine and ID. So I already knew one of them, and there was only maybe 3 or 4 HIV consultants. And the relationship between pharmacy and the consultants in HIV had already been established before I was there. They were very pro-pharmacy. They relied on us a lot for information. But then I guess there was quite a lot of pressure because I was new to the HIV field and they're asking me all these questions. And I think one of the things doctors can identify quite quickly is when you do and don't know the answer. And they don't like blagging the answer. If you blag the answer either, you can't get away with it. And yeah, not knowing the answer, to be honest, I didn't struggle too much with that, because I think from like the on-calls, I switched my mind frame from like being really anxious about a doctor or a nurse asking me a question to actually by the end of it, I thrived. And I was like, yes, ask me questions. Like, it challenges me. It makes me think. I want to learn more. So I wasn't kind of phased at that point too much by questions being asked at me. But I think in that environment at Ealing, it was a lovely environment. And we were very needed. What was quite different was when I went to Chelsea and Westminster for HIV. And Chel West looks after like over 10,000 HIV patients. It's the biggest HIV unit in the whole of Europe. So, I knew I really wanted to work there because of that. But on the other side, you've got the biggest names in HIV working there, and they don't need pharmacy, or they don't think they need pharmacy, and there's a lot of egos and stuff. So I went from this lovely family feel pro-pharmacy environment to, not really needed, just, get on, do the job kind of thing. So that I found very difficult. And yeah, that's kind of, the big teaching London hospital vibe that I didn't like. Because there's pros and cons of like the district generals and the big teaching hospitals. You know, you learn a lot at both. And I think depending on the type of person you are, you know, you come across stuff you don't know, and it's up to you whether you want to go away, look it up. And teaching hospitals, you probably have a little bit more information giving it to you freely accessible. Whereas at the district general hospitals, you haven't really got the hierarchy as much. And so you get given more stuff or more responsibility. So, you know, from like early on days, you know, okay, you can write that DTC application, you can do a ward round by yourself, you can, you know, supervise students, pre-regs, whoever. It wasn't like, oh, you can't do that until you're a band 7, or you can't do that until you're an 8A, which was great. But yeah, on the other hand, Chelsea, I did learn so much because I was learning from the experts in the field. And I think that is where, you know, all of my kind of ingrained HIV knowledge came from there. So I'm very grateful for that experience. But yeah, it was quite a big contrast to what I was used to.
And what was life like living towards sort of London?
I did, to be honest, I fell in love with London.
Okay.
And I moved from Harrow to Wimbledon, which was a lovely area. I mean, the district line could have been better, but yeah, it was great. And I lived 2 minutes down the road from my friends. So, yeah, we moved kind of together as well. And it's funny because I always kind of thought, oh, I'd never want to live in London. And then here I am, like 7 years later, I can't see myself leaving, which is mad. It kind of just like sucks you in a bit. Yeah, where were we? Chelsea.
Yeah, I've always wanted to live in London. So when we moved back from Abu Dhabi, we wanted to be near our parents simply because we both didn't have jobs. We had nowhere to live, and we kind of like lived with parents for a couple of months until we kind of got jobs and knew where we would be going. So I actually got a job at Stoke Mandeville, which is around the corner from here. I covered a maternity leave contract, which was partially clinical and then partially looking after the pre-reg program. So it was 3 days a week pre-reg director. Then I went back to Oxford because it's less than an hour's drive from here, and went back to emergency admissions and just was locuming, and they let me choose the times I wanted to work. So I used to work 7:30 to 3:30.
Amazing.
And it was great. Like it was, you know, the shift where you're just really busy the whole time, that you're doing loads of drug histories. I was getting back into kind of like the NHS and the clinical aspect of working because I had 2 very different jobs when I worked in Abu Dhabi, and I wasn't so clinical. So it was a really good experience to kind of like get back to grips with what I was used to as a resi. I knew everyone in the department. I knew their systems, where information was kept. So it was such an easy transition back to the NHS from that perspective. And it was a great opportunity to kind of feel more comfortable back home again.
Yeah.
And it gave me part of my life back, because that's where I was trained, and that's where I felt like an amazing machine pharmacist, you know, when you're in your resi life. So, you know, we moved back home, and we were living out in the countryside. But obviously, when COVID happened, the trains would cancel constantly because the drivers would be unwell. So I would be at Euston sometimes for 90 minutes, if not more, in the evenings, waiting for the next train to get home. And I had a 2-year-old, so I would see her like once every 4 days, because I would leave in the morning before she would wake up. And then by the time I got home, she'd already be asleep. So sometimes it would be 3 or 4 days and we just wouldn't see each other. Our contract for renting was coming to an end. And at that point I was like, look, we're kind of free to move wherever we want to. My husband's work was all kind of going to be online, so he could work from home. So it didn't really matter in terms of location. And I was like, maybe we should move to central London, because I've always wanted to live there, and being closer to work would make life a lot easier for us as a family. And we've got the freedom to do it. We're not we haven't bought a house yet. So we moved to North London in Queen's Park near Kilburn. And boy, was it a different experience. COVID was an issue because it was very cramped and you couldn't do much. And at that point, lockdowns were still going on. The second wave then hit. So, you couldn't do anything. You would go to the park with your children and there would be over 100 parents in the park and it was just not COVID friendly. But there was nowhere else for people to go at that point. And when you're in London, there's really limited, green space compared to where we are now, where I literally walk outside my doorstep and I'm in the Chilterns. I could walk anywhere and not see anyone for 5-6 miles if I really wanted to. And that's what we were used to in the first lockdown. But there were benefits. I was able to run to work or jump on the Bakerloo line and it was, 25 minutes door to door. Running to work was 6 miles, a nice 10K run in the morning. And we were living in Scrubs, right? So I could quickly shower and jump into Scrubs during the day and not worry about clothes even. So that, made life easier. I was home by 5:15. I could cook dinner, spend time with my family, and routine improved. But it was just the social aspect and we felt very cramped in the flat. We had issues with neighbours being really noisy, buses on the road, like police cars driving by on a regular basis. So from that perspective, then I realised this is not for me. As much as I wanted to enjoy it and I wanted to experience the London life and having all the fun museums and activities and restaurants and music and all of the things I wanted to expose my child to. And as a family do stuff together, we just didn't get the opportunity to do it. So we quickly realised that we needed to leave for mental health reasons as well. Like we felt so, just cramped in a flat with no garden and no outdoor space and you're constantly either at work or at home. And that was really hard for us. And now we have a lot more kind of freedom with the outdoors and we absolutely love being in the countryside. But then now my commute is really long. So, it's really difficult to figure that out. But when you're, I guess, living on your own and you're not, married with kids yet, it's actually a lot easier to then do all that exploring and figure things out. And you're not uprooting multiple people in your household to try and figure out what works for you and what doesn't work for you. But it was a good learning experience. But I wouldn't go back and live in the city again, I don't think.
Yeah.
Unless I was like a millionaire and I had like an amazing like penthouse flat and, all of the rest of it that comes with living in London. Yeah, living the dream. But the small space just, it's a challenge.
Yeah.
So I guess when you were working at Chelsea, you were enjoying your role, but what kind of made you then, you got your 18-month itch?
I got it, yeah.
Okay,
that's what happened. So, Chelsea was great that it was also rotational. It was the specialist HIV rotational job. So, because they have so many patients they look after, they had so many clinics in different areas of London. So you've got the one at Chelsea Hospital, main one, and then you've got 56 Dean Street in Soho. Then I was at Hammersmith, Broadway, and then they also merged with West Middlesex Hospital, so I would rotate there as well. So I kind of didn't get too complacent because I was rotating all the time, and then we would still, one of the rotations was like covering the HIV inpatient ward. Not a lot of hospitals have like a specific HIV ward, so that was incredible to work there. But I wanted like the next step, the next challenge, and I wanted to do my prescribing and I wanted my own like HIV pharmacist clinic. And at the time that wasn't really possible at Chelsea. So some AA HIV jobs were coming up, and one came up at Guy's, and it was a maternity cover. And I knew kind of a bit about GSTT's reputation. They're very pro putting pharmacists on the IP course, and the HIV unit already had pharmacist-led HIV clinics. So I was like, oh, perfect. But then at the same time, I also got offered a permanent AA HIV job at St George's, which was much closer to home. And people that know me know like I'm very risk averse. So the thought of going into a temporary contract and potentially not having a job at the end of it, I was like, oh, I'm not sure, versus a nice, cushy, permanent job right next to home. But I kind of knew in my gut I need to go for the GSTT job, so I accepted that one. And yeah, it really hasn't disappointed. I was put on the IP course within a couple of months, even though I was a temporary member of staff. And then I had my own clinic. Every Monday, I'd see HIV patients when they were starting the drug, and then I'd follow them up afterwards. So you had like that continuity as well, which was great. And then during COVID, to kind of, help with the nursing demand, I was able to get trained up in phlebotomy. So in that clinic, I'd be able to do everything for the patients, all the medication side, and take their bloods at the same time. So that was quite kind of a cool skill to learn, which I guess not a lot of pharmacy. I know, like, we're giving more vaccinations and stuff in the community, but that kind of clinical side of it was really great. And I mean, the amount of opportunities that we get at GSTT are endless and amazing. So, I feel so lucky to have been there. And whilst I was doing the mat cover secondment, my manager was able to put in a business case for a new AA HIV pharmacist job, which I went for during my time. So then I became permanent. So I was like, yes, okay, done.
Ticked off the list.
Which was great. And I think that has been the longest job I've actually stuck out. I think I did over 2 years before I switched to my current job now. So yeah, I thoroughly enjoyed it.
How was it transitioning from a band 7 to a band 8A role?
Initially, you get that kind of nerves when you're stepping up. But I kind of felt ready because I'd done 18 months HIV at Chelsea. I'd done like a 6-month rotation at Ealing. I thought, how much more experience do I need? Like, that should be enough, right? But it was still, going into an even bigger teaching hospital. And, the expectation of what an AA should do. But
expectations are quite high at GSTT.
Yeah, they are. I mean, our standards are, but yeah.
It's good. It's a good thing. It's hard. It's challenging. But in terms of career progression and, your skill set in terms of multitasking a million things at once, it's a great environment to be in, as long as you've got the personality to fit that. And then it doesn't become overwhelming and turn into burnout. But expectations are high. And one of the things in terms of those expectations that's really good is there's a lot of opportunity to teach junior pharmacists and support their education and training, which is really, again, really rewarding from a different perspective. Like, you're not with patients, but you're with your own profession, and you're helping to teach them and grow into what you've been through.
Yeah.
And that mentorship is quite an exciting part of career progression. And it's a really exciting field to be in. And because you're so passionate and proud of where you work, obviously they must enjoy their rotations and their time with you. Were there specific kind of responsibilities that were new to you, whether that might be kind of getting funding for things or kind of formulary applications and things like that you felt kind of a little bit out of your comfort zone at all?
Yeah, there was lots of stuff. I think my manager at the time would be on leave with, let's say, maybe not much of a handover. And so we'd kind of have to almost step up into his role. So I'm kind of, learning how to be an AA, but then also stepping up into his role and managing the whole team, or manage the clinic, manage sickness, manage annual leave, loads of kind of rotas. And yeah, it was a lot of responsibility, I thought, at the time, but actually it was great because I'd learned so much. And there was no kind of, how do I say, there was never a no at GSTT in terms of like what I would want to do. So I became a pre-reg tutor. I supervised like the MSc international student research projects. If I wanted to do any kind of like quality improvement research idea, I could just run with it. And that was just fantastic. And like going to conferences, I've been able to present work. I went to like Switzerland a couple of years ago at one of the European HIV conferences, which was incredible. And then beginning of this year, I was able to, I'm not quite sure how I did this, but got, I think, 6 posters and an oral presentation at the conference this year.
That's amazing.
Yeah.
That's something to be really, really, really proud of. That's a great achievement.
I think it was kind of because Omicron happened last Christmas, maybe that Christmas before. And so there wasn't much socializing. So I was like, oh, I may as well just bash out a few posters.
No, that's a great opportunity to learn, and a great opportunity for you to like go to conferences and go to other countries. Can you kind of share, I guess, your journey into getting involved with research and abstracts and posters? How did you get started with that?
I did my first one when I was at Chelsea, and basically a lot of the work kind of I've done is kind of retrospectively looking back at our cohort, doing audits and seeing what's happened. And it could be anything. At the time there, it was a drug we used called efavirenz. And when it went off patency, switching patients to generics, which like in community pharmacy, you wouldn't really think of switching a patient's generic medicines, just whatever you buy in, I guess, and hand out. But in HIV, it's a very kind of, I don't want to say precious cohort, but switching the medicines is a huge deal, and just changing the packaging of the box is a lot. And so I looked at how people tolerated it and did they get side effects. And I reviewed, I think, 2,000 patients' notes, which was insane. Staying back like a couple of hours every day, data inputting.
Was it paper back then?
It was electronic, thank God, imagine. But I really enjoyed it, and to be able to kind of answer that question, which wasn't written in the literature already, I just thought that's so exciting. And, you know, that bit of information that I did in that audit has like changed my practice going forward. So like when I'm counselling patients on generics, say, I know that potentially, you know, X percentage of our patients got this side effect, and I've got that information to hand to counsel patients, which is just incredible. And that's our own work, our own cohort. And then, yeah, when I moved to Guy's, the kind of my passion just grew more and more with research. I was able to go on this course called, if I can remember the name, Clinical Research Protocol, where you basically learn how to create a whole clinical research protocol from scratch. And I did that on kind of evaluating what happened with our HIV patients during COVID. So we had to basically strip back a lot of the monitoring because we had to reduce all our outpatient activity. And what that meant was patients wouldn't have their 6 monthly bloods. So usually they have their viral load, which is like the amount of virus in the blood. Every 6 months they come in. and get this done. But during COVID, we kind of had to make the decision to defer these bloods for another 6 months. So instead of getting it every 6 months, it was yearly. But we know that, for the majority of our patients are undetectable. Their virus is at such low levels. Does it make a difference if we move to annual monitoring rather than 6 monthly, which was kind of like ahead of the guidelines at that time? Like, how confident are we to not monitor patients that regularly? And so I reviewed, again, I think it was about 1,500 patients who had their monitoring deferred during COVID, and looked, okay, when they came back to clinic, what happened to them? How many of them were able to still suppress the virus? Did we miss stuff? Did we miss like the kidneys going off? Did we miss liver abnormalities? That kind of thing. And I mean, the data was so good. And I was able to present that as an oral presentation this year at one of the conferences. And not only that, is it actually kind of changed our practice in our HIV unit. And the data that I gathered from that, we were able to use it to define a new pathway in the service. So we called it the stable patient pathway. And so if people met a defined criteria, as in, for the last 2-3 years, they've never kind of had a virus blip, they're stable on their medication, we're not concerned about vulnerabilities, mental health, comorbidities, patients can opt to kind of go into this stable patient pathway and have monitoring done every year versus 6 months. And so they haven't got to come into clinic every 6 months, which can be quite stigmatizing for some people as a reminder to have to come back to the HIV clinic. And so, yeah, it's been really rewarding knowing that like this work has actually, it's not just like a poster, it's actually like changed something.
Service improvement.
Exactly,
all the way.
that's the word.
I love it. I love it. I love service improvement. For me, like, that's another thing. Counselling and education of patients, and then service improvement and making like quality changes to services is something that I find I'm really passionate about in any aspect of pharmacy, not just, palliative care. I do some work with formulary, and it's really exciting to see the developments in what, information we're providing, or how that app works, how people can get access to the information. It's all, I love that kind of change. I love to see the change. And I love that when people are using it, they get excited that there's this piece of information that didn't exist before, and it's helped them with a patient at the end of the day. So no, that is really exciting, especially when, that's 6-7 years of experience that you've got in pharmacy, and you've been able to achieve that. And I mean, tell me your thought processes. Where do these ideas just kind of come up as you're doing the job? Is that just how your brain works, and you just think, okay, well, I don't know this and I want to know?
Pretty much, yeah. Okay. So there's a gap. You ask a question, like, why don't we do this? Or why has that happened to that patient? Is this like a common theme?
You're curious in nature.
Curious, yeah. And particularly kind of minority groups as well. So one of the piece of work I did for that conference as well was looking at our HIV-2 cohort. So not everyone is aware there's 2 different types of HIV viruses, HIV-1 and HIV-2, and the most common in the Western world is HIV-1, but there is a kind of a sub-cohort of people with HIV-2 virus, which is much more difficult to treat. Some of the drugs don't work against it. And generally, it's in a kind of ethnic minority cohort as well, people from West Africa. And the pharmaceutical company don't really test the drugs on people with HIV-2. so quite a neglected cohort as well. And at Guy's, we had quite a big cohort of HIV GP patients. Now, there's only around maybe 300 people in the UK with this compared to the thousands and thousands with HIV-1. So I knew I kind of needed to collaborate with other clinics because my data alone isn't as strong as, you need big patient numbers. So I kind of put the message out to the other HIV clinical pharmacy leads in London, and we're quite lucky that we have quite a strong network. There is a HIV London Leads meeting that happens every month or quarter, and so you kind of have access to them, you know who they are. I've obviously worked with a few of them before along the way, and I kind of put the feelers out there. Hey, this is a bit of a neglected cohort. No one really knows what drugs we're using in them. The guidelines isn't based on a lot of evidence because there is not much evidence out there. Why don't we do a bit of a retrospective cohort looking at these patients? And I was able to collaborate with 7 hospitals in London. The data was really interesting. Patients were on all these different regimens. And it was presented as a poster at this conference beginning of this year. And the way the conference works is you go there and then some of the posters get chosen to be an oral presentation, but you only find out when you're at the conference. So, and I'd had like 6 posters at the conference. So this poster got highly commended and chosen for an oral presentation. So you then have a day to prepare and you present the next day in front of like however many people it was, 300-400 people. But you're at the conference all day. So then you only have like a few hours in the evening to prepare for this. But I think that was almost better because it was more conversational. I didn't really have time to prepare like a whole script of what I was going to say. And I think that morning I'd given the COVID data presentation in the morning. So I'd kind of gotten over my fears of like presenting at that conference. And then mid morning, I gave the HIV-2 presentation, which was like really well received. I had people coming up to me after the conference asking questions and stuff. But to be able to kind of collaborate as well with so many different pharmacists and trusts was so rewarding.
That sounds like a really good experience. And we have the same in pediatrics. We reach out to other hospitals in terms of the network, and it, even with when drugs shortages, for example, like diamorphine just magically disappeared, and you're like, well, what are we going to give?
And why don't we do this more? Why don't we share knowledge? I feel like everyone's in their little silos.
Exactly.
And not...
I think we're doing it slowly.
Yeah.
But there's so much more we could do. I mean, organisations like UKCPA are creating all sorts of specialist, subject areas where people can talk to each other on forums. In paediatrics, obviously, we've got the MPPG group where we do talk to each other, and there's a conference every year. People are collaborating with formulary. For example, for paediatrics, we have collaborated with all the South East London hospitals in terms of the peds groups. All the pharmacists now, we meet up every month on Teams, and we have actually segregated parts of the work. So, Kings do liver, we don't have liver, so some of the drugs that relate to that, they're updating the monographs, for example. We have a big neonatal unit, so, Sean's doing a lot of the neonatal work. So that collaboration is slowly coming into effect.
That's great.
The crazy part is, for me, is that there are pharmacists like us all over the place. There are people who are thinking forward, how we can improve, how we can collaborate. But where do we find the time So, you know, you're doing this on top of your day-to-day job, and you know that like this is going to make a true impact to your patients. It's very rewarding. You're learning, you're meeting other people, you're making these connections, which is a great part of the job, because you're going to learn from those trusts as well. Like, okay, we've been doing this in practice. Maybe this would work for GSDT, for example. So there's endless opportunity for enjoyment, for learning, etc. That collaboration is really, the feedback from that is very rewarding. But you have to do this on top of your normal job. So GSDT are great at allowing us the opportunity to put forth as many ideas as we want, but sometimes they don't give us the specific time. It has to just be done. Just get it done. Just get it done. You know? I guess one of my questions, and what people might be thinking listening to you, is that I know you mentioned that during coronavirus and having lockdown that you spent a lot of time doing this data collection. Is that, how do you manage your time? Because you're leading a team, you're running clinics, you're thinking about conferences, putting posters together, doing all that data collection, even giving these presentations. You've got to spend time preparing for them. Your oral presentation skills obviously need to be on top form when you go to a conference, for example, in Switzerland. Like, that's a really exciting experience. But again, like, there's a skill that comes with that, having to present to potentially hundreds of people who are listening to you.
Yeah.
How do you manage your time to get all of that done?
I mean, it sounds like all I do is pharmacy, but I do have a life as well. I'm not just like data crunching every evening. And I guess some of the things which we were talking about this morning was this book I read a few years ago called Miracle Morning, which is a very kind of American self-help type book, but it really did help me at the time. And essentially there's kind of a few different things you do in the morning to set yourself up for the day. One of them's exercise. So I wake up at like 5:30, 6 every morning, go to the gym, do a spin class, a HIIT class. One of them's meditation, so I'll meditate for like 5-10 minutes. One of them's affirmation, so just writing down your kind of goals, what you want to achieve that year or even just that day. And then another one's like journalizing. So I'll journalize kind of like how I'm feeling, what I've got planned for the day, all random thoughts. And it kind of just gives me a focus and structure. And when I'm feeling like overwhelmed or stressed in the day, I find I can manage situations much better, like having done that, if that makes sense. And I've got kind of like strategies to kind of cope with stress. And it's funny, like if I don't know, I've been out the night before drinking and I haven't been able to wake up in the morning and I haven't done all this, I'm completely off all day. But having this kind of structure, and I love a checklist. I have a checklist for everything. I'll have like each day I've got Monday, Tuesday, Wednesday, Thursday, Friday, what I've got to do that day. And just looking at that in the morning, I generally always get things done. So I mean that's really helped me. And I guess I always want to come home feeling like I've done everything I wanted to do. I hate carrying things over the next day. I just like, ticking things off, being productive. So yeah, that's kind of my life strategy.
It's a great strategy. I'm with you. And I talk about this all the time on the podcast, because I'm always trialing different types of strategies in terms of health and well-being. Because at the end of the day, once you look after your body and your mind, your productivity at work is completely different. The amount people always say to me, how do you do all of that? How do you manage a family, commute 3 hours a day, essentially have 2 jobs, one at King's, one at Evelina, and within Evelina you're split into multiple directions. You're doing palliative care, you're doing formulary. Like, how do you get that done? And a lot of it is looking after my mental health, and a lot of it is setting up my morning so that it looks similar to yours. Whether that's waking up to exercise, being mindful, being intentional with what my day is going to look like, and planning things ahead of time. I bought a diary where it gives you your kind of like 6 a.m. all the way to 7 p.m. and each hour of the day I have a plan. Each hour of the day there is something to fill in that area. Of course, like, that could be quite overwhelming for some people, but even if it means take a nap, it's scheduled. My time is scheduled. I have kind of 3 goals that I have for the day. Things can be as simple as making sure I drink 2 litres of water to the more complex, getting 2,000 bits of data collection done by the end of the day. Like, you know, it can really vary. Even with the podcast, like, I have to do this outside of my 9-to-5 job. So finding the time in the evenings and scheduling time on the weekends and working with my husband on this schedule, because at the time we had 1 child. So if she was at Stagecoach on the weekends, like from 9 to 1, I would be able to study when I did my IP. He would look after her from 9 to 1 and I would just bang out loads of work. And that was my private time to do it. And yes, it's on the weekend, but at the end of the day, if I want to achieve the goals and I want to move forward with my career, or I want to tick things off my list, like you say, things have to be scheduled in place, otherwise they're not going to get done. So that makes a massive difference, and it does reduce your stress, because when you start ticking things off, you feel good inside that like you've got this done. So from a mental health perspective, you feel like you've achieved a lot. And even if they are really small jobs, like preparing my lunch for the day the night before, or making sure that I have a really healthy breakfast to set me up for the day, it makes a big difference. I guess, like, we've talked a lot about the specialty area that you're in. What kind of networks, apart from knowing the pharmacists in the London area, are you part of in terms of HIV? Like, there are, you know, groups, and what are you doing to work alongside them?
So we have a HIV Pharmacy Association called HIVPA, which I kind of joined as soon as I got into the speciality, and we're really lucky to have it. And in terms of how I kind of get involved with that, one of the things I do is I lead on the patient information leaflets that HIVPA provides. So, you know, who wants to read the manufacturer's patient information leaflet? And, you know, the list of side effects that are on there, you know, you would never want to take any tablet. So we kind of try and make patient information leaflets which are patient friendly, you know, not medical jargon. And it, you know, it simplifies it to kind of what are the main things you need to know. And, you know, what side effects are, you know, common, but transient, that you build a tolerance to. What side effects are actually you need to worry, and this is when you need to escalate and come and see us. And then at the back we have like contact details, so we add you know, we have like a patient email that patients can email into, and a telephone number, so you've got that kind of follow-up there as well. And I mean, during COVID, we were able to like email these to patients as well, because, you know, we can counsel patients over the phone, but then do they absorb all that information? Then we've got the leaflets to send out. So I do that with a group of pharmacists. And we kind of, when a new drug comes in, we write the leaflet together, approve it, and then it gets put on the website. So all which is kind of not password, you know, anyone can access that. And HIVPA, you know, do lots of other things. They have, their own conferences, they have study days. So I was quite honoured. In the last HIVPA conference, I was asked to give a talk about my current job role that I'm doing now. And when I was asked, I was like, really? Me again? Yeah, it was really great to kind of talk about what I'm doing. So in my job role now, so I moved from HIV pharmacy to it's a 8B secondment as PrEP and sexual health pharmacist. So I actually don't do any HIV at all anymore. But PrEP is, for those who don't know, pre-exposure prophylaxis. So people who are HIV negative can take a tablet when they have condomless sex, and it will prevent them from getting HIV. So this has really been a game changer for HIV. This job is completely different to anything I've done before in pharmacy, to be honest. It was great to kind of talk about it in that conference. And now I've got pharmacists from all over the country emailing me about questions about how we run the service. I'm thinking, God, they think I'm some kind of expert in PrEP. I'm not. Well, I'm trying. But yeah, it's been great. I guess, on today, I kind of wanted to talk a bit about my current job.
Yeah, absolutely.
If that's okay. And so I started it July this year. So it's only been kind of 4 or 5 months into the job. And I went from being a team of one of 6 HIV pharmacists to moving to the sexual health services, and Guy's and Tommy's being the only pharmacist there. So I kind of work completely silo, which at the beginning I was like, I miss my friends. But I am kind of a bit of not a loner, but independent, and my time is my time now. So I'm not set to a rota or anything. I can literally just decide all my meetings.
Living the dream.
Yeah, it literally is. But in doing that, I kind of had to do my own induction. So I just basically emailed random names I heard in sexual health to kind of meet up, do introduction meetings, and then try to build connections with the nurses, doctors, in order to kind of go and shadow their clinics. And the welcome was a bit mixed, if I'm honest. So sexual health services have a very light touch from pharmacy. There's very few actual sexual pharmacist jobs, and the role I'm doing now is the only one in the country. There's a few European PrEP pharmacists, but there's nothing like this, which is incredible. But it means, the sexual health services have kind of been untouched from pharmacy since whenever they started. So you can imagine the medicines management problems which are there, that it's just kind of a free-for-all. And I think they weren't sure who I was and what I'm there to do. So it was kind of some of them were like, oh great, we've got a pharmacist here, they're going to sort out all of our stock issues and help us with queries. And then the other team was like, oh, she's like the medicine police, she's going to come down on us on all of this stuff. So I really had to work on building relationships and kind of, assuring them that I'm here to help and support them. I'm not here to write datexes on all of you all day. So that was kind of tough at the beginning. But my primary job role was implementing and building a PrEP service, which PrEP had been around for a few years. but it wasn't streamlined at all. So say if a patient comes into clinic and they want PrEP, they could see a nurse, they could see a doctor, they could see a health advisor. And so it wasn't really streamlined at all. And there's a lot of politics between the different staff groups as well. So you've got nurses against the doctors, health advisors against this and that, and then you've got politics between the staff groups as well. And I'm in the middle, like trying not to cause any other conflict. But I kind of knew, okay, so I need to build a service here, but I need the people working in there to help me. I need a team. I need the stakeholders engagement. How can I say, right, we're going to do X, Y, Z, fall into place, everyone? It's never going to work. So I basically emailed the department every week to say, hey, join our PrEP team, come and get involved. And I would corner people in corridors to be like, hey, do you like PrEP? Are you interested in PrEP? And I was able to build a team of, now we've got 12 people in our team from all different clinicians, health advisors, admin team, reception, doctors, nurses, consultants, registrars, band 7 nurses to band 5, healthcare assistants. And we've been able to kind of like come together each week. I chair a meeting, minute it, and we talk about service development. And I think, you know, without all their input, none of what I've kind of done so far in the job would have been successful. And I guess the other thing coming in was I knew that PrEP needed to be a nurse-led service. That was kind of set from the commissioners, is that's what they want. They want it to be run by 70% like band 6 staffing. So I knew that was kind of like my aim. But then unfortunately, prior to me coming, the nurses had been kind of not shot down a bit, but basically it had been kind of described to them that PrEP was really complicated and that only a doctor could do it. And so the nurses were underconfident with PrEP. They didn't want to use PGDs. They didn't really want to get involved that much with PrEP. Not all of them, but some. And they'd been given so many PowerPoint presentations on PrEP, so that wasn't working. So I was like, okay, I need to do something different. So I basically set up these PrEP training clinics. So every afternoon I would sit with a nurse and we'd see patients and they could either watch me seeing the PrEP patient or I would observe them, and we'd just kind of lead the consultation together. I would ask questions which I thought were necessary. I'd give additional advice and we'd kind of learn. And I did PGD sessions with them as well. And now kind of 3 or 4 months in, I've trained every single nurse and every single one of them uses a PGD for PrEP. So, yeah, it's been amazing.
It sounds very different,
yeah,
and very rewarding in a different way.
Exactly.
How did you get the funding to set up this job?
So it's my job is funded by the commissioners, so the local authorities commission sexual health services, and Lambeth and Southwark have the highest HIV diagnosis rate in the whole of England, and that's the GSTT catchment area. Yeah. That's what our sexual health services cover. So Guys and Tommies were given X amount, I don't know, of money, and one of it was spent on a pharmacist, one of it was spent on a nurse admin team. And coming into the job, it was meant to be me and the nurse doing this, but they never recruited into the nursing role. So then it was just me.
Lone Ranger.
Lone Ranger.
But it's really exciting, and you're utilising a whole host of different skills. And in some ways, when you start a new job, which you're building from scratch, winging it, and trying different things is actually really exciting, and you can see what works and what doesn't work. How many patients are you kind of seeing on a day-to-day basis?
So we have around, I think, 2,000 patients a year on PrEP. but each day, so I've set up afternoon nurse-led PrEP clinics, which is great because it's streamlined the service. The sexual health clinics are open 8 till 7. So in November, we're going to expand it to an all-day PrEP clinic, which will be 12 patients a day.
Okay. You spend quite a lot of time with them then,
yeah,
in each session. What kind of things do you kind of discuss with the patients?
So there's loads of stuff, and so part of it is obviously to do with the PrEP. So how are they taking it? There's various different ways you can take it depending on who you are. So men who have sex with men can take it daily, or this event-based dosing, so just taking it as and when you think you're going to have sex. But then heterosexual and women can only take it daily, just because that's how they've done the trials, and how long it takes for the drug to get into different areas, tissues in the body. So we go through how they're taking it. Are they adherent to it? So obviously, if they're not taking it properly, they may have had a HIV risk. So there's a lot of counselling and support with that as well. And then if they have had a risk, the biggest problem in PrEP is giving PrEP to someone who has HIV, because PrEP is a HIV drug in itself, but it's only half of a HIV regimen. So if a patient presents and they've got HIV and you give them PrEP, you're basically giving them half of what the virus needs, and the virus will mutate, get resistance. And when they come to their new diagnosis HIV appointment, they're already going to be resistant to some of the drugs. So you're setting them up for failure. But the testing, you can test for HIV, but there's window periods. So you can do like a finger prick test, but that has a 3-month window period. So that will only tell me if the patient had HIV 3 months ago, not if they've contracted it in the last 3 months. And then the venous blood test you do has a 45-day window period. So if they've had a risk a week ago, I'm not going to know if they've got HIV at that point. I'm only going to know if they do a HIV test 45 days from that risk. But then if you don't give them PrEP, they might have a risk in between, and then they haven't got access to PrEP. So it is quite tricky.
Yeah, definitely. So I guess communication and getting the patient to be as informative as they can be and as honest is really valuable in that clinic.
And so that's just, I guess, the PrEP side of things. But then you've got to check what's their sexual history. So you're having really intimate conversations. So when was the last time you had sex? Who did you have sex with? What kind of partner was it? What kind of sex did you have? Was it unprotected? Where are they from? Do you know the HIV status of the partner? And then asking them how many partners they've had in the last 3 months. So you're asking quite intimate questions, but they are attending a sexual health clinic, so it's not like completely out of the blue.
But still quite a different side of pharmacy that you don't necessarily have the training. Again, like these kind of conversations can be quite challenging if you were relatively newly qualified and quite uncomfortable.
Absolutely.
So today, going out your comfort zone is not as bad as you thought it was.
I know.
No, that's really interesting though, and a really exciting kind of aspect of your role. What's your most favourite part of this new job?
Service improvement.
Okay.
Yeah.
We're on the same pathway.
Yeah.
In so many ways. That's quite interesting. Yeah. Service improvement I love it. I have so much passion for it. It's an enjoyable part. And I assume you'll be doing a lot of research in this as well, because it's all new and exciting. I guess, what do you see going forward for yourself and for this job? Because I'm sure you've got ideas to build a team, or you'd like to have funding to build a team. But what do you see for yourself in the future?
I mean, I would like funding for this job to stay permanent as well.
Okay.
So it's a 1-year secondment.
Okay.
So yeah, the commissioners have only paid for a year. They won't pay for anything more. So we've got to do a business case for either pharmacy to pay for it or the directorate budget to pay for it, I guess. But then, you know, there's so many other roles I think pharmacists could do in sexual health, particularly prescribers. You know, why can't we have PrEP prescribing clinics? In November, I've set up, I'm going to have my own clinic as well every Thursday morning. So I'll be able to see kind of the complex PrEP cases. So, you know, our PrEP that we use on the NHS, you can't use in chronic kidney disease. So I'll be seeing those ones, drug interactions, the side effects, the intolerances, that kind of thing. So yeah, I'll be able to do that. And then the next step, which I want to do with the job, is the whole problem with kind of HIV and PrEP is that we need to target the vulnerable groups. So PrEP is like very well advertised, and the kind of gay community, men who have sex with men, are very well informed about PrEP. They know about it. They know how to get it. They know how to even buy it online before it was in the NHS. But the new HIV diagnoses we're seeing are in kind of Black African heterosexual communities who don't know about PrEP and who are really vulnerable. So my next thing is to kind of like, how do we work in the community to target these people? And something I'm working on at the moment is with a primary care pharmacist. And what we're going to try and do is she's going to do a travel clinic attached to, say, like a GP surgery, and hopefully pick up, you know, Black African women who are travelling back and forth, or, for example, their partners who are travelling back and forth, who are having other partners and are at risk. And then she'll be able to either give PrEP there or refer them to me, and I'll be able to put them into in touch with our sexual health clinics. So yeah, hopefully that will be a great partnership, which is really new and exciting. But there's a lot of challenges of red tape involved with this. So yeah, it's a long way to go, but I think we'll be brilliant if we pull it off.
Well, you're making a start by making those connections, aren't you? So it's definitely there's a lot of excitement to come. Oh, I'm so excited for you.
Oh.
I got so much more out of this podcast than I thought in terms of getting to know you and
I'm glad,
you know, hearing your journey. And there's a lot I'm sure that the listeners and the viewers of the video podcast will have gained in terms of what pharmacy is all about and what we're capable of, and showcasing, you know, the profession in such a positive way. So, you know, thank you so much for going out your comfort zone today and coming all the way to my home and spending time with me this morning.
Thank
Perfect.
you.